In late 2019, reports began emerging from Wuhan, China, of a mysterious cluster of pneumonia cases. At first, it looked like a local outbreak, a new respiratory illness spreading among people in one city. But within weeks, the world was facing something much larger. The cause was identified as a new coronavirus, later named Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2. The disease it caused became known as COVID-19. What made the outbreak so dangerous was not only that it could be severe, but that it could spread efficiently before the world fully understood it. By early 2020, infections had moved beyond China into other parts of Asia, Europe, North America, and eventually almost every region of the planet. The global response accelerated as health authorities realized that this was not an isolated emergency. On January 30, 2020, the World Health Organization declared the outbreak a public health emergency of international concern. That designation is used when an event poses a risk to multiple countries and may require coordinated international action. Then, on March 11, 2020, the WHO assessed COVID-19 as a pandemic. A pandemic does not simply mean a disease is deadly, it means it is spreading widely across countries and continents. By that point, governments were no longer preparing for a possible crisis. They were already inside one. One of the reasons COVID-19 was so difficult to control was the wide range of illness it caused. Some infected people had no symptoms at all, while others developed life-threatening disease. Common symptoms included fever, sore throat, cough, and fatigue, but the experience varied dramatically from person to person. This variability created a major public health challenge. If every infection had been obvious, isolating cases would have been easier. Instead, people could spread the virus while feeling only mildly sick, or sometimes before realizing they were sick at all. That made the pandemic harder to see, harder to track, and harder to contain. COVID-19 spread mainly through airborne particles released when infected people breathed, talked, coughed, or sneezed. Early in the pandemic, much public attention focused on surfaces, hand washing, and physical distance. Those measures still had value, but over time, evidence made clear that shared indoor air was central to transmission. Crowded rooms, poor ventilation, and prolonged close contact created ideal conditions for the virus to move from one person to another. This helped explain why outbreaks often occurred in workplaces, care homes, restaurants, religious gatherings, and households. It also pushed public health advice toward masks, ventilation, testing, and reducing high-risk indoor exposure. As the virus spread, it also changed. Mutations produced new variants, and some of those variants had advantages over earlier forms of the virus. A variant might spread more easily, partially evade immune protection, or cause different patterns of disease severity. This did not mean the virus was changing with a plan. Mutation is a normal part of viral replication. But when millions of people are infected, the virus has many opportunities to generate new versions of itself. Variants complicated the response because public health strategies and vaccine expectations had to adapt. The pandemic was not a single static event. It was an evolving biological crisis. The measures used to slow COVID-19 were among the most disruptive public health interventions in modern history. Governments introduced travel restrictions, quarantines, lockdowns, business closures, mask mandates, testing systems, and contact tracing. The goal was to reduce transmission, protect hospitals from being overwhelmed, and buy time for treatments and vaccines. But these measures came with difficult trade-offs. Closing schools affected children and families. Business restrictions threatened livelihoods. Limits on gatherings disrupted religious life, culture, sports, and community rituals. Public health officials were not only fighting a virus, they were constantly weighing disease control against economic damage, social strain, and individual freedoms. Hospitals became the front line of the pandemic. In hard-hit areas, health systems faced shortages of beds, staff, protective equipment, oxygen, and intensive care capacity. medical workers treated waves of patients while facing the risk of infection themselves. The pressure was not evenly distributed. Older adults, people with underlying health conditions, and communities with less access to healthcare often faced higher risks. The pandemic exposed long-standing inequalities in health systems and social conditions. It showed that vulnerability is not only biological. It can also be shaped by job type, housing, income, geography, race, and access to medical care. A major turning point came with vaccines. COVID-19 vaccines were developed and tested at remarkable speed, with public deployment beginning in December 2020. This rapid timeline was possible because of years of prior research, massive funding, international collaboration, and the urgency of the crisis. Vaccines did not make the virus disappear, but they sharply reduced the risk of severe disease and death, especially when widely used. Distribution, however, was unequal. Wealthier countries often secured doses earlier, while many lower-income regions relied on international programs such as COVAX, which aimed to improve vaccine access. The vaccine rollout became both a scientific achievement and a test of global equity. Treatments also improved over time. At the beginning, doctors had limited tools and were learning in real time which therapies helped and which did not. As research advanced, treatment strategies became more effective. Care included symptom control, oxygen support, better clinical protocols, and eventually antiviral drugs designed to reduce the risk of severe illness in certain patients. These improvements mattered because pandemics are not fought with one tool alone. Vaccines, treatments, testing, masks, ventilation, and public behavior all played different roles. The response became more layered as scientists and health systems learned more about the virus. Beyond health, COVID-19 caused a global social and economic shock. The pandemic contributed to the largest global recession since the Great Depression. Supply chains broke down or slowed, leading to shortages of goods, medical supplies, and in some places food. Panic buying emptied shelves, while factories, ports, farms, and transportation networks struggled with closures and labor disruptions. At the same time, reduced travel and industrial activity briefly lowered pollution in many places, creating a striking but temporary glimpse of how human activity affects the environment. The pandemic revealed how interconnected the modern world is, and how fragile some of those connections can be under stress. Daily life changed in ways that were once hard to imagine. Schools and universities closed or moved online. Public spaces were restricted. Weddings, funerals, concerts, sports seasons, and major cultural events were canceled or postponed. For many white-collar workers, telework became normal almost overnight, reshaping expectations about offices and commuting. But not everyone could work from home. Essential workers in healthcare, food supply, transportation, cleaning, retail, and emergency services continued in person, often with greater risk. The pandemic created a divide between those who could retreat into digital life and those whose jobs required physical presence. The information environment became another battlefield. Misinformation spread through social media and sometimes through mass media, confusing the public about masks, vaccines, treatments, death counts, and the seriousness of the disease. Political tensions intensified as people disagreed over restrictions, mandates, school closures, and personal liberty. The pandemic also raised painful issues of discrimination and blame, including racial and geographic targeting of communities associated with the virus. At the same time, debates over health equity became more urgent. COVID-19 forced societies to ask who gets protected, who gets believed, who gets treatment, and whose risks are considered acceptable. In May 2023, the World Health Organization declared that the public health emergency caused by COVID-19 had ended, while emphasizing that the disease remained a global health threat. By 2025, many experts generally considered the pandemic phase over, with COVID-19 transitioning into an endemic phase. Endemic does not mean harmless. It means the disease continues to circulate in a more persistent, expected pattern. Different definitions of a pandemic can lead to different opinions about when it truly ends. As of August 5, 2026, COVID-19 had caused more than 7.1 million confirmed deaths, with estimated deaths ranging from 18.5 to 35.2 million. It became one of the deadliest pandemics or epidemics in history, and its legacy continues in medicine, politics, work, education, and collective memory. If you found this helpful, please like this video and subscribe for more explainers.